Hi, good morning everyone. I am Dr. Varadaraja, Senior Neurologist, Nandyal. Today we are going to discuss about a refractory epilepsy in an adolescent girl. Here is a brief abstract of the case. A patient with an epileptic syndrome with the polymorphic seizures, with predominant myoclonic seizures, with onset in infancy, and with febrile status epilepticus, which were very refractory to multiple drugs, and even she was required chelosotomy also. Coming to case details, a 13.5-year-old female born to non-consanguineously married parents with normal birth history presented with seizures. They were of 12 years 3 months duration by the time she presented to us. Seizures were started at the age of 9 months with prolonged GTCS with fever. That was febrile status epilepticus. Since then, she used to getting GTCS with or without fever. Along with GTCS, she also had multiple episodes of myoclonic jerks, almost 30 to 40 times per day. She had 4 episodes of febrile status epilepticus by the end of 2 years. And the myoclonic jerks were resistant to therapy, and she also had left focal seizures with bilateral spread. Coming to the development, she was normal till 1.5 years of age. Subsequently, she developed impaired language development, learning disabilities, and hyperkinetic behavior also. There was nothing significant in the family history. Examination revealed severe degree of mental retardation with the mental age almost 3 years. Investigation done by the time she was presented to us, electroencephalogram revealed generalized epileptiform discharges. MRI revealed small sized brain, otherwise normal, and all other metabolic workups were normal. She received multiple trials of drugs, and she also was undergone chelosotomy surgery also for refractory epilepsy. To summarize the case history and examination, an adolescent girl born to non-consanguineously married parents with normal birth history and development till clinical presentation. She was presented with complex febrile seizures followed by polymorphic seizures with predominant myoclonic epilepsy refractory to treatment. And she had developmental delay and mental retardation with normal imaging and metabolic workup. So the epileptic syndrome with onset during infancy, which is progressive with complex febrile seizures and severe myoclonic epilepsy. The differential diagnosis usually considered a spectrum that extends from febrile seizures to Dravet syndrome and progressive myoclonic epilepsies like Inverrich and Lindbergh and neuronal ceroidal hypophysionosis. But clinically, this patient fits into Dravet syndrome as per Hattori et al. Screening test. Hattori et al. Described a screening test for the prediction of Dravet syndrome before 1 year of age. Before 1 year of age, this girl had so many predictive risk factors. The predictive risk factors are onset less than 7 months, total number of seizures 5 or more than 5, hemiconvulsions, focal seizures, myoclonic seizures, prolonged seizures, hot water induced seizures. If the clinical score is 6 or more than 6, we can perform sodium channel 1A mutation analysis to confirm the diagnosis of Dravet syndrome. In this case, the index case scores 7 before 1 year of age as per history. Dravet syndrome was described in 1978 as a severe myoclonic epilepsy of infancy. Angel called as it Dravet syndrome and classified under epilepsy syndromes. ILAA, Indian International League Against Epilepsy, classified Dravet syndrome under epilepsies and syndromes undetermined as generalized or focal seizures. Brief discussion about Dravet syndrome. It begins in first year of life, more often in the first 6 months, with the tonic-clonic seizures almost always triggered by fever. Protracted febrile seizures, that is febrile status epilepticus, in an otherwise normal child. Between first and fourth year of life, additional febrile and afebrile seizures appear. Afebrile seizures are more frequently unilateral, tonic-clonic, or secondary generalized. They evolve later to other types of seizures also, which include myoclonic, atypical absence, atonic, alternating partial seizures, and convulsive status epilepticus. Early psychomotor development is normal before convulsions. Developmental stagnation in the second year of life happens. Later, neuroregression accompanied by hyperactivity, language deterioration, and mental retardation develops. Claes et al. Examined for and found mutations involving sodium channel 1A in 2001 and stated that sodium channel 1A is the main gene responsible for severe myoclonic epilepsy or Dravet syndrome. Other studies also confirmed mutation of sodium channel 1A gene in most of the patients, but not all affected. The prognosis of Dravet syndrome, febrile seizures stop and other seizures become less evident in second decade. Myoclonic seizures are very resistant to therapy. The periods of high recurrence is associated with more severe neuropsychological impairment. Coming to treatment aspects of Dravet syndrome, certain points we have to keep in mind while treating Dravet syndrome, because certain anti-seizure medication they exacerbate seizures in Dravet syndrome. So iatrogenic injury can occur. So establishing the diagnosis of Dravet syndrome is important, very important. The anti-seizure medication that aggravate seizures are phenytoin, phenobarbital, carbamazepine, and lamotrigine. The drugs that frequently used with some results are sodium valproate, clobazam, topiramate. The drugs that are considered to be useful are stiripentol, fenfluramine, and cannabidiol. Alternative therapies, ketogenic diet, it has a controversial role. To conclude, keep a watch for Dravet syndrome. If an infant presents with complex febrile seizures followed by febrile and afebrile seizures, which include GTCS, partial with bilateral spread, and refractory myoclonic epilepsy. Do sodium channel mutation analysis in suspected Dravet syndrome patient. Accurate diagnosis is required to correctly prescribe anti-seizure medication to explain the prognosis to parents for parent and patient education. Thank you.